Welcome, future nurses, to today's Clinical Explainer. We're going to be walking through the essential clinical pathway of geriatric cognition. So we'll be moving step by step from the normal aging baseline all the way through to assessing true pathology. As nursing professionals, getting a solid grasp on what's actually happening in the aging brain is absolutely crucial for providing that high-quality, compassionate care we're all striving for.
Okay, let's just kick things off by asking a pretty fundamental question about the aging mind. Do we ever actually stop learning? Seriously, think about it. And in what ways can we keep learning, literally no matter what our age is? How you answer this is going to completely shape how you approach patient education. I'll give you a quick spoiler alert right now. The learning never stops. But the way we process that new information, well, that definitely evolves.
Here is our roadmap for this explainer. We're going to cover 1. The normal aging brain, 2. Fluid versus crystallized intelligence, 3. Assessing patient cognition, 4. Administering the mini-cog, 5. Navigating late-life anxiety, and finally, 6. Depression and trauma.
Section 1. The normal aging brain. Establishing the baseline.
There is a massive misconception out there regarding the aging nervous system. Yes, it's true, neurons do gradually decrease in number and shrink in size. And yeah, we also see some myelin loss, especially in those peripheral nerves. But here's the absolute most important takeaway for your clinical practice. Overall cognitive function does not inherently deteriorate. Honestly, a lot of areas and functions remain completely intact. Normal aging does not just equal a loss of mental function.
Section 2. Fluid versus crystallized intelligence, the shift in cognition. So, to really understand this, we need to distinguish between two specific types of intelligence. On one side, you've got fluid intelligence. Think of this as skills that are biologically determined. It's completely independent of experience or learning. We're talking raw processing speed and reaction time. And it's true, older patients do tend to perform more poorly on these performance scales as they get older. But then, look at the flip side. Crystallized intelligence. This is that deep, deep well of knowledge and abilities acquired through decades of education and just living life. In healthy older adults, scores on verbal scales, which is what measures this crystallized intelligence, remain amazingly stable.
As a future nurse, you have to leverage that crystallized intelligence. When you're teaching older patients, you literally cannot just hand them some generic pamphlet and expect it to stick. The information has to be totally relevant to them. You want to relate new medical instructions or lifestyle changes directly to their vast life experience and what they already know. And of course, always consider their literacy level and cultural variations. Remember, many older adults are incredibly adaptable. They're the fastest growing age group owning computers right now. If you respect their accumulated wisdom, I promise you your patient education is going to be vastly more effective.
Section 3. Assessing patient cognition, first impressions and rule-outs. Listen, your clinical assessment actually starts the exact second you lay eyes on the patient. Long before you pull out a clipboard or a formal questionnaire, you should be observing. Are they dressed appropriately for the current weather? Like, are they wearing a winter coat in July? Are their clothes clean? Is the patient well groomed? Do they interact with you readily, or do they seem kind of withdrawn? Pay really close attention to their facial expressions, how they move, their posture, and any distinct speech patterns. These general observations are basically your super powerful early indicators of their cognitive well-being.
But hold on. Before you even think about jumping to a cognitive or psychiatric diagnosis based on those observations, you have to play clinical detective. Always perform a physical exam first. A sudden dip in cognitive function? That might just be an acute physical issue. You absolutely have to rule out the usual suspects, like an electrolyte imbalance, simple dehydration, poor hearing or vision, or even a vitamin deficiency. Heck, even an underlying UTI or infection could mimic cognitive decline. Fix the physical stuff first.
Section 4. Administering the mini-cog, a hands-on clinical tool.
Once you've ruled all that out, administering this screening is a highly effective, super straightforward 3-step process. Step 1. Tell the patient to listen carefully and remember 3 completely unrelated words, something like apple, pencil, telephone, and have them repeat them right back to you. Step 2. Hand them a blank piece of paper with a circle on it and ask them to draw the face of a clock. Have them put in all the numbers, and then set the hands to a specific time, like 10 past 11. And finally, step 3, ask the patient to recall those initial 3 words from earlier. When you actually do this in practice, you'll see some fascinating attempts at the clock drawing. Sometimes the numbers are totally disorganized. The reason we do this is that the clock drawing actually serves as an incredible informative distractor. The scoring algorithm is pretty simple. If they recall 0 words, they are likely demented. If they recall all 3, likely non-demented. But if they only recall 1 or 2 words, that's when you look at how they drew the clock. An abnormal clock flags a much higher likelihood of dementia, which instantly helps you clarify those tricky intermediate scores.
Now, if your screening does happen to flag an issue, we really need to use exact clinical terminology. We've got to distinguish normal, healthy memory shifts from specific diagnoses. Take age-associated memory impairment, or AAMI, for example. This involves early changes specifically in the ability to retain and store immediate, short-term, or long-term information. This isn't just someone casually getting older, This is a defined clinical observation that definitely warrants closer monitoring.
Section 5. Navigating late-life anxiety, not a normal part of aging.
Here's the thing. Older adults are rarely going to just come right out and report psychological symptoms directly to you. They might have this pride of independence, or they just stoically accept their difficulties. So it's on you to proactively look for cues and risk factors. Are they experiencing frailty, vision impairment, or maybe a sudden drop in social support? Have they had any recent high-stress life events or a new diagnosis of a different illness? Believe it or not, even certain medications can trigger anxiety. You really have to look at the whole holistic picture, because anxiety is so often just the presenting symptom of a deeper underlying issue.
And for patients who are survivors of traumatic events, especially our veterans from military conflicts, we must be highly, highly vigilant for PTSD. It can happen with both direct and indirect exposure to trauma. You're going to want to watch closely for the 4 major symptom clusters. That's re-experiencing the event through flashbacks, avoidance behaviors, persistent negative alterations in cognition and mood, and severe alterations in arousal. That last one looks like being excessively jumpy or having totally unexpected startle reactions. Knowing your patient's life history is absolutely essential here.
Section 6. Depression and trauma, identifying the signs.
Often, depressed older adults experience this profound lowered self-esteem, intense helplessness, and a total loss of control. I literally cannot state this strongly enough. Depression is not a normal part of aging. It's just not. It is a severe clinical issue that requires our immediate nursing intervention, whether that's through non-pharmacologic methods or getting them on the proper medication management.
You need to be hypervigilant whenever your patient is undergoing a major life transition. Think about it. An admission to a skilled nursing facility, losing a spouse to widowhood, the sudden onset of chronic pain, or losing their physical health. These are massive, massive risk factors for situational depression. Even the side effects of new medications can cause really dramatic mood changes. As their nurse, you are right there on the front lines, and you're the one who can spot these triggers before the depression deepens.
So I want to leave you with this final provocative thought. As future nurses, how is your ability to differentiate normal aging from true pathology going to alter the trajectory of your patient's life? Honestly, your precision in assessment, your refusal to just dismiss symptoms as, oh, they're just getting old, and your deep, genuine respect for your patient's crystallized life experience, that is the absolute key to their clinical outcomes. So keep learning, keep observing, and keep advocating fiercely for your patients.